So our next speaker will be Will Holland. He's a fourth-year medical student from University of Leeds. He's done a project with Professor Dave Sanders with regards to eating disorder. So he's come down from Leeds to Sheffield not only to eat his mother's lasagna, so he's going to talk to us about SCOFF.
Thank you very much for having me today. I'm looking forward to doing the talk. There's been some wonderful ones so far. Today I'm going to talk to you about SCOFF in GI disorders. So I'd like to start by talking about this gentleman, Lord Byron, who makes a rather bold statement that he'd rather not exist than to be large, something which he achieved by eating only one meal a day, and this incredible behaviour of wearing 7 waistcoats and a greatcoat to play cricket in. And he was showing what we'd call today disordered eating behaviour, and probably if he'd been born 200 years later, he would have received a diagnosis from one of the many eating disorders found in the Diagnostic and Statistical Manual of Mental Disorders, which we can thankfully shorten to DSM-5. And I've used this phrase disordered eating behaviour, but what does this actually mean? Well, this is different from an eating disorder, and it's really important to clarify that point. So disordered eating is a spectrum, and you can see that right in the bottom of this pyramid, on the right-hand side, that it doesn't always require clinical attention. So if somebody's just skipping the odd meal, counting calories, there isn't a reason for clinicians to get involved. What disordered eating is an early warning sign, essentially, for an eating disorder. So you can see that as behaviours get more frequent, as it become more extreme, you could work your way up the pyramid towards a threshold eating disorder. And the take-home message from this slide is in that little yellow circle, red circle, sorry, going colourblind, which is that everyone with an eating disorder shows disordered eating, but showing that disordered eating doesn't always mean you have an eating disorder. So that's the difference between the two. You're probably thinking, well, we're gastroenterologists, we're not psychiatrists. Why am I here talking to you today about eating disorders? Well, the reason is that eating disorders are prevalent in GI conditions, and the predecessor to them, disordered eating, can be seen in up to 40% of patients in gastrointestinal clinics. These patients have increased rates of anxiety and depression, they have a reduced quality of life, and ultimately the patients at the top of that pyramid that I showed you on the early slides with the threshold eating disorders are more at risk. So if you've got a hospitalised patient with IBD, you're at 10 times a greater risk of dying if you also have anorexia. And the trouble is that eating disorders in disordered eating is often overlooked. They're not regularly screened for, and actually the questionnaires that you use to diagnose them just take far too long for other clinicians to use. So if you've got a 15-minute clinic appointment, using the EDE, which takes about 45 minutes to do, just isn't practical. Now, when these questionnaires were used in a cohort of IBD patients, the prevalence of an eating disorder using these questionnaires was around 25%. Now, these same patients were interviewed by a gastroenterologist, and they failed to pick up any of the disordered eating in these patients, which gives gastroenterologists as a tool a sensitivity of 0. So you can see the need for a tool that we can use to identify this behaviour and stop it progressing up that ladder where the patients can come to harm. And I'm here to pitch you today the SCOFF questionnaire, which has been the backbone of my research for the past year. And you can see that this is a 5-question questionnaire. It will take around 30 seconds to do, and it asks patients these 5 questions. Do you ever make yourself sick because you feel uncomfortably full, so self-induced vomiting? Do you worry you've lost control over how much you eat? Would you say that food dominates your life? So these are altered perceptions and relationships around food. Have you recently lost more than 1 stone in weight, so any weight loss? And do you believe yourself to be fat when others say you were too thin? So body image disturbances. And actually, if patients score 2 or more on this questionnaire, that suggests they're at risk of an eating disorder. And actually, it's relatively sensitive and specific when used in practice. So these are the results from 1 year of my life. And I think anybody sharing the office with me for the past year will have hated my telephone voice and probably wanted to kick me out of the room. So I called up as many patients with gastroenterology clinics as I could and got some controls. And you can see in the little red box where we tested the main hypothesis, which was that we thought disordered eating would be more prevalent in GI conditions than in controls. Now, we found that it was more prevalent, but that this wasn't statistically significant. But you can see it's around 5 to 6% in controls and up to 18% in IBS. Since I couldn't go on holiday over the summer, I couldn't go find myself in Bali, I found myself in the gastroenterology office collecting some more data. So I managed to get some more IBS patients, and actually now we've found that statistical significant difference. So disordered eating is more common in GI conditions, specifically a lot higher in IBS. We did also identify some risk factors for disordered eating, so namely if somebody had a psychiatric disorder, that put them at 3 times the risk of having disordered eating, as did having a younger age, which is known in the literature, and also recent weight loss. With the last one, it's important to note that there is a lot of overlap in symptoms between eating disorders and GI conditions. So just because somebody's lost weight, patients with IBD lose weight, patients with celiac disease lose weight. So it's about recognising, is this something to do with the organic disease process, or is this a psychological thing that's come from people's eating behaviours? So I think SCOFF could be integrated into your clinical practice. You can see that it is brief. It would take around 30 seconds to do. You don't even have to ask the patient it. You could give it them on a slip of paper. And as Nick Trott was saying earlier, it's important to screen patients, particularly those who are going on any sort of dietary therapy, because you don't want to be giving somebody who's already got disordered eating patterns and sticking them on a low FODMAP diet and restricting that food intake even more. You're also in a privileged position where patients know and trust you. If you have sort of long-term follow-up with them, they might open up about this behaviour more, because if they're just seeing their GP or haven't seen before, it is a sensitive issue, and patients are probably, say, more likely to speak to you if they know you and you've got that rapport. And you're probably thinking, well, I give somebody this questionnaire, they score 2, what does that actually mean for me? And I think there is a sort of a lack of evidence base out there in terms of what to do. A couple of papers have given small amounts of guidance, and this is to some extent anecdotal as well from my research, but talk to patients, see if they think they have a problem with their eating, see where that problem stems from. Is it from putting them on a diet? Is it from their own behaviour? Have they got that body image disturbances? And it's important to ask these questions, and SCOFF is a perfect tool to start that conversation. Obviously, you can inform their GP. We have a great set of dietitians in Sheffield, and they can obviously help patients who are maybe struggling with their eating if they're on one of them imposed diets. We're also looking to have a self-referral service for an eating disorder, so you can signpost patients to SAIDA, which is the South Yorkshire Eating Disorder Association. So you can send patients here without needing an actual clinical diagnosis of an eating disorder, and they can talk to somebody there. There's also great online resources. So the Beat Eating Disorder website has a helpline for patients, loads of things that they can read and get information from there. And ultimately, if you're worried about them, then you can always refer them to a psychiatrist if you think that's clinically appropriate. And the key message with why I'm trying to tell you to use SCOFF is because the early bird really does catch the worm. We know that disordered eating is prevalent in GI conditions, therefore eating disorders are. And right at the top of that pyramid, if you can catch patients before that point, you really are going to help them and improve their outcomes and make them better, quicker, essentially. So I'll take any questions. Thank you very much for listening.
Are there any questions from the floor?
No? Wonderful.
Thank you very much, Will.
Thank you very much.